Good evening, everyone. Here Imran Abbas. Again, we are live, another session with Professor Mohamed Abouzeid from Egypt. It is great honor for me to be live with Professor Mohamed Abouzeid. Professor has excellent experience in anastomosis, gastric bypass, and he has a crucial role for especially promoting this procedure, this anastomosis, gastric bypass, all over the world. Professor, really appreciable, and it is great honor for me to be with you. Sir, please, over to you, sir.
Thank you very much. I'm really honored to be with you, and thank you, Professor Amran, Dr. Amran, for the nice invitation to join you today. I'm sorry, I just finished my work. I came so fast. We are late 10 minutes, so I'm really sorry. All right.
Sir, excellent. Sir, as you know better, so now we are going to finish our series of MGB, OAGB. We have started this series about 5 months ago with Professor Robert Rutledge. So in this, especially COVID era, what was the purpose of such an activity? To share experience of such a legends with the youngsters, with the world. So we have started with MGB, that is, you know better than me. Now going to popular surgery, especially bariatric surgery or weight loss surgery all over the world, not only in a special region. So definite, as we know, and all, so people, those who are related to bariatric surgery, they know one of the most experienced person is Professor Mohamed Abouzeid. Sir, because we have some repeated questions, because at the end we will have a sum up session. So your brief introduction, sir.
Okay, brief introduction about myself. I'm Professor Abouzeid. I'm professor in Ain Shams University, one of the biggest universities in Cairo and in Egypt, and in the Middle East. It's well-known university. We have a specialized unit in our university for bariatric surgery, and has eminent bariatric surgeon in it, and one of the biggest bariatric surgery units in the Middle East. On the private base, I have my own clinic, the Perfect Health Clinics, and it was started 2007. Till now, we performed more than 6,000 cases, and I can say that personally, I was involved as a surgeon or assisting in like 7,000 cases, maybe like 3,500 cases of one anastomosis gastric bypass. In 2016, we published some data with some colleagues, and it was very, very good results of one anastomosis gastric bypass. I will discuss with you in the later questions how we changed our technique all over the years. But I can say right now that my practice, I have like maybe 40 or 50% of my cases are sleeve still, and I have like 30 or 40% of my cases one anastomosis gastric bypass, rare cases of classic bypass who has GERD or severe GERD or Barrett's, and I have like 10% of my practice redo cases. Maybe now it's like 15% case, 15% of my cases are redo cases.
Sir, excellent, really, and it is great honor. So, as you have mentioned earlier, so sir, so because these are repeated question, as I have mentioned earlier. So, when you have started MGB and why you have started MGB?
Why? Okay, in 2011, I think. We were convinced that MGB is, after Frankfurt meeting, we were convinced that the OAGB or MGB is having great popularity, getting more and more popularity all over the world. And so we started with my brother Osama Taha. We started in 2011 to 2000, end of 2010 and in 2011. We started to have some patients who were convinced that they can do the one anastomosis gastric bypass. We tried cautiously in the first year with some patients, and we had some criteria to choose, and we were very cautious. We were following the basic science of Rutledge, Weigely, and at that time, we found out that it is very easy operation. After years of doing the classic bypass, we found out that it's easier operation, and we found out that it has very good outcomes. Of course, we had modifications all the time to have it more good results and less complications, and we'll discuss it later. But I mean that at that time, the science drove us to start to try this operation, and this is the key point, that science. And I really want to thank Wijili for his work after Routledge. Routledge is my friend, and I always thank him for this idea. But I mean that the scientific work after Routledge by Kular and by Wijili also gave some credibility for the operation and for us to start to try to make one osmotic gastric bypass formations for our patients, and we had very good results, and we completed in our series. And till now, I think 10 years of experience in one osmotic gastric bypass, and I don't regret that I'm one of the surgeons of one osmotic gastric bypass in the world right now.
Professor, excellent. As you have mentioned, so definitely you have changed some steps of this vanosmosis gastric bypass for better results. So, can you highlight? So, now you are about more than 1 decade. You are doing this and following this procedure for better results for patients as well as because we are surgeon, we are scientists. So
Okay.
also for our patients, if patient will be happy, definite, so you will have more patients and you will achieve better results. So
Yes.
what's
Yes.
the question? Which steps you have changed
Yes.
and why you have changed these steps?
Okay. First of all, when we started, we used to do 2 meters bypass biliopancreatic limb. And after 2016, when we published our results, we found out that we have 10% of iron deficiency anemia of in our patients. And I decided that I will do for the low BMI 150 centimeters, biliopancreatic limb, 180 centimeters for the all basic patients, and for morbid, superiorly morbid obese, super obese, I will do 2 meters. And this is the first modification to lessen the BP limb to the minimum, and this had great impact on on the iron deficiency anemia and on the vitamin deficiency. And I didn't see malabsorptions and hypoproteinemia and low after this modification. The second modification is that from 2016 I use the 3 millimeter anastomosis, linear anastomosis. In the past we used 60 millicentimeter anastomosis, and it was very big. And we found out that the bile will be 3 centimeters more up in the pouch because we are doing linear anastomosis. So if you do 6 centimeters, so you add 3 centimeters of bile up there because you are going up with 3 more centimeters. So what we do right now is 3 centimeters anastomosis and closing the defect. And the 3 centimeter anastomosis gave us less bile reflux, more weight loss because it has some restriction compared to the 6 centimeters in the past. The other modification is that I tend over the years to lengthen or make it more the pouch more long. So right now I usually start above the incisura, above the antrum, at the below the incisura, above the antrum, and I go like the sleeve. I usually take 4 to 5 60 millimeter cartilage to finish my pouch. So I think it's very long pouch. It's usually like 25 centimeters, and this definitely changed the outcome of bile reflux in the patient. Right now, I really see patients with evident bile reflux after the OAGB. Long, narrow pouch on 36 fresh bougie Of course, it is lax over the 36, but it's still over 36 French bougie. Long narrow pouch, 3 centimeters, anastomosis, 180 basically for all patients, centimeters BB limp. This is my technique right now. I'm very satisfied with it, and I think that in the last years I see less and less complications because I modified my.
Sir, excellent. Sir, as you have mentioned, so regarding low BMI, so you prefer 150 centimeter. So which patient you ask low BMI? What's your definition of low BMI?
For me, with the one man-associated gastric bypass, low BMI is 35 with comorbidities. I don't do one osmosis gastric bypass in BMI less than 35, except in very rare cases, type 2 diabetes on high doses of insulin, where I can go to 32 BMI. So basically, from 32 with insulin-dependent type 2 diabetes till 35, we consider it as low BMI. When I do this kind of patients, I make the same pouch, long, narrow pouch, because if I do wide pouch, I will definitely have bile reflux and I will definitely have malnutrition. So I'm not with the saying that we will say that doing the low BMI will give you should do wide pouch. No, don't do the wide pouch. The wide pouch will give you bad bile reflux. Make the long, narrow pouch the same technique, but bypass only 150 centimeters, and I don't see malnutrition or patients going less than the ideal weight with this technique. They usually go to the ideal weight and they usually stop diabetic medications, or they are on only one medication per day.
Sir, excellent. So this is the good news also for those who are following metabolic surgery, because overall all types of bariatric surgeries are metabolic. But overall, this terminology when we talk, so metabolic, it means that targeted for treatment of diabetes. So this is the message. So if in low BMI with diabetes, so MGB is effective, but
Yes, very effective.
you can do standard MGB with BP limb 150.
Yes.
Sir, in redo surgery, if a patient with weight regain after sleeve gastrectomy, have you another criteria or same BP limb?
Yes, after sleep, I usually tend to, if the BMI after, because some patients after sleep come with BMI like 38 or 39, and they want to do one osmotic gastric bypass. So if the BMI is 35 to 40, I will still be at the 180 centimeters. If the BMI is above 40, I will go to the 2 meters. I don't go right now to the 2.5 meters in the redo. I used to do it like 4 years ago, but right now I usually stick to the 2 meters only. But the point about the sleeve is that you have to re-sleeve the pouch. Most of the surgeons who do one osmotic gastric bypass after the sleeve say that it's malabsorptive and I don't need to re-sleeve or plicate the pouch, but and they do more malabsorption. But I found out that the patient has a better results and less malnutritional complication if you stick to 2 meters and you re-sleeve the pouch, because most of the patients with previous sleeve either have a stricture at the incisura and they are sweet eaters, and then you will find proximal dilatation at the fundus, so you will need to resect the fundus again, or these patients had inappropriate sleeve, wide sleeve, and you need to re-sleeve it again. So in both scenarios, in all my patients, I usually re-sleeve the pouch. I think I have a small video prepared for you. Can you just
Yeah,
tell me
please,
share
please.
screen? Okay,
Yeah, sure.
I will share. Okay, okay.
So here you can see downside there is a icon for share screen.
Mm-hmm.
You can click that.
Okay. Go. Yeah.
Have you clicked that icon? So this is share screen,
Yes, I clicked it.
but we cannot see.
Okay, 1 second. Window share. Okay, can you see it now?
Yeah, yeah. Now I can see.
Okay. 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 1 second. Mhm. Can you see the video right now?
Not yet. So, but we can see your screen.
Can you see the video?
No, no.
Okay, 1 second. Okay.
This is Wi-Fi and also something
Okay.
like this. I can see here.
1 second. Okay. I'll try. Okay. hmm
Yes, just a minute. I will.
Yeah, I have a video here.
Yeah, yeah.
Okay.
Now we can
Okay.
see your video.
If I can have the control, because I need to fasten a little bit
Yeah, control. You have your control. No issue.
in the
This is
video. Okay.
yeah, yeah. This is redo surgery.
Yes, this is the redo after sleeve, but I think I can. hmm
Again, your video has been stopped.
Yeah, I'll try to play it with other program. 1 second.
Okay. Can we enlarge the size of video?
hmm hmm hmm
So there are a lot of adhesions.
Yes, yes, yes. I'm just trying to get you an edited version of the video to make it easier. Uh, okay, I can't. All right. I can control the video, but as you can see here, that we have a lot of adhesions, and we are trying to dissect the sleeve. This patient had like band and then open band and then removal of open band by another open procedure to remove the band, and then she had sleeve and she lost lots of weight after sleeve, and then she came back to us with another adhesions and weight regain. So as you can see here, but I can see the edited video. Okay. Okay, I'll just exclude this one. Okay. And I'll give you a short one.
Professor, my question. So
Okay.
especially in redo surgeries.
Mm.
So are you prefer to measure whole bowel length or no? Just your standard is 200. So there is no need to measure whole bowel length.
Yes, in redo cases, I don't count all the whole bowel length, except in one case if the patient is presenting with insufficient weight loss after one anastomosis gastric bypass, or if the patient is presenting with malnutrition after one anastomosis gastric bypass. In this instant, I will count the whole bowel length. But in my opinion, it's waste of time and risk of perforation of the small intestine if you count the whole length all the time. So I don't prefer that. So I don't count all the whole length. I have my standards. I put the 2 meters for all the redo cases, except in very, very few cases when I can use 250 centimeters in long patients like 190 centimeters with huge bodies. I can go for 250, but in as a standard in the redo, I use the 2 meters and it's satisfying for me. I used to count the intestine before, and I found out that most of the patients, like for every 100, like 97% have 6 to 7 centimeters, 6 to 7 meters of small intestine. All right, maybe you'll have 1 or 2 cases of abnormal length, like 5 or 9, but I won't count the whole length in all the patients for 1 or 2 cases per 100. It's a waste of time. I'm putting risk for a patient to have some intestinal perforation, and most of the surgeons, all AGB surgeons around the world, don't count till now the whole intestine. So I'm not different from the other surgeons.
Excellent. So another thing that is the main concern still, and you know better than me. So if we see about 1 decade before, about 15 years ago, the same issue, that is the main concern. So marginal ulcer and bile reflux after MGB. So
Mhm.
definite. Now we have changed lot of changes. We can see technical changes. This MDT protocol and different things. Still, it is concern.
Uh, for marginal ulcer, it's yes, it's an issue if the patient is a smoker, if he has a lot of non-steroidal anti-inflammatory drugs. So I would say that if the patient has a tendency to smoke and doesn't stop smoking, or he takes lots of non-steroidal anti-inflammatory drugs, I'll just tell the patient don't do anything, or maybe make sleeve. But for the one anastomosis gastric bypass, you can't ask a patient smoker and taking non-steroids to have the one anastomosis gastric bypass. And if he started smoking after the one anastomosis, I think it's better to scope the patients at least every 2 years, if it's not every year. In our practice, we don't see a lot of marginal ulcer because we select our patients, and I usually tell the males who are not diabetics to do sleeve, not one anastomosis gastric bypass, because our males in Egypt are smokers. So I hate to do smokers one anastomosis gastric bypass. I do sleeve for them. And some patients have starting marginal ulceration with medical treatment, with eradication of H. pylori. We don't see the marginal ulceration. The other thing is that our osmosis is low; it's above the antrum, and we found out that when you go low, you has you have a less incidence of marginal ulceration. I don't know, maybe because the long pouch has some acid, and the bile has a buffering effect on the acid, and it's a equilibrium or equation. They are equilibrating each other. I don't know why we don't see. Thank God we don't see lots of marginal ulcer. Sometimes we see it, but it's not that much. The other question with the marginal ulcer was the bile reflux, or
Yeah, bile reflux, because this is always a concern from, you know
okay,
better than me. So international conferences we
okay,
face.
yes. All right. Bile reflux is basically surgeon's fault, basically, because I see like 60% or 70% of videos that I see from the Roux-en-Y surgeons or sleeve surgeons who are not accustomed to the one anastomosis gastric bypass doing short sleeve, short pouch. Still, they are convinced that it's very long because they are used to the Roux-en-Y pouch, which is very short. So if they go to the incisura and they do a pouch like 3 firings, they will say that this is long pouch. But for me, it's still short pouch. For me, the long pouch takes at least 4 longitudinal or vertical firings, 6 centimeters. So I think that it's at least 20 plus the pouch length. This is the first thing. The second thing is that some Some surgeons do the lax pouch. They do it like a big pouch, and especially in the low BMI. And in this kind of patients, bile goes from the intestine to the big pouch. It stays overnight, and sometimes the patients wakens up like in the early morning or in the middle of the night saying that there is bile in his mouth. This is because the big pouch will reserve some bile in the big pouch. The third thing is that if you go with your anastomosis, longitudinal linear anastomosis up in 18 millimeter pouch, 18 centimeter pouch with a 6 centimeter anastomosis linear, so you will be 12 centimeters from the gastroesophageal junction, and this is very, very near for bile to go to the esophagus. So I ask all my friends who do one esophageal gastric bypass, please make very long pouch and do the 3 centimeters anastomosis so that your bile will be at least 18 centimeters from the esophagus, real the real uh, measurement, not the anastomosis, because the anastomosis 6 centimeters anastomosis will put the bile 12 centimeters from the esophagus, and this is very short. If we have this criteria, long narrow pouch, 3 centimeters anastomosis, uh, I think that the bile reflux will still be available or present in our patients, but it will be like 2% and treatable with diet control. And we did, since we started this kind of technique, we didn't reverse any patient for bile reflux.
Sir, excellent. So another question. So regarding GERD before surgery. So GERD, yeah, definite. This is a wide definition. But a patient with the symptomatic GE reflux, so acid reflux, definite. This will be acid reflux and also documented. So your endoscopist will confirm. Have you any experience of MGB in such a cases?
MGB with acid reflux?
Yeah, patient suffering with acid reflux before surgery.
Yes.
Symptomatic, documented, yes.
Symptom, yes, but what kind of reflux? Mild reflux, severe reflux, hiatus hernia, GERD, I mean Barrett's esophagus. I usually I usually do one anastomotic gastric bypass for patients with mild acid reflux, because most of these patients they have mild reflux because of the obesity. And if they have mild esophagitis, I will do still one anastomotic gastric bypass. If they have severe reflux or Barrett's esophagus, I will do Roux-en-Y gastric bypass.
So in this mild reflux that just you have mentioned, so overall in morbid obese patient, they face mild reflux and also documented. You face also this esophagitis was also present, and you did MGB in this case, and condition become worse after surgery. So because now you have a vast experience about 1 decade,
No, no,
have
no,
you?
no, 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 no. I'm sorry. I'm sorry to interrupt you, but this doesn't happen. Mild acid reflux, and then you do one anastomotic gastric bypass, they will get better. Okay, in 95% of patients, they will get better if you do the one anastomosis right. In my perspective, because the patient has acid reflux in his esophagus. Okay, so we are not adding acid to his problem. Okay, and we are giving him easy way for the food to move from the pouch to the intestine, and we are putting the anastomosis 20 centimeters at least from the esophagus, so the patient has easy transit of food from the stomach, from the esophagus to the stomach, to the new pouch, to the intestine. Okay, yes, he may have some bile in his pouch, but definitely he won't have bile in his esophagus if he has mild reflux with competent sphincter or semi-competent sphincter. If the patient has severe reflux with incompetent sphincter, I will do for him Roux-en-Y, because this patient will suffer from bile in his esophagus, not acid in his esophagus. So Roux-en-Y to avoid the bile in severe incompetent cardia. But I'm not afraid of the increasing the acid reflux.
So my question, so because now definite, maybe this is our concern. Because now I have discussed with many surgeons, so many of them they are doing one anastomosis gastric bypass till in severe esophagitis, and there is no issue. So maybe still we have some concerns about this. So maybe it will increase. So if we do, because now till if I name so Professor Robert Lutridge, Kolar, so they are doing, and many of them, also many of other surgeons, they are doing one anastomosis gastric bypass in severe esophagitis, and there is no issue, no problem. Professor, I cannot hear you.
All right.
Yeah, I
All
can
right.
hear.
So, in my opinion, it's easy to do Roux-en-Y gastric bypass. It's not that hard. Severe reflux may have, in my opinion, incompetent cardia, and I'm not doing the one anastomosis gastric bypass in these patients to avoid the acid reflux. I'm doing the Roux-en-Y gastric bypass to avoid bile in the esophagus from the severely damaged incompetent cardia. This is my view of the patients. I didn't try before to do one anastomosis in this kind of severe patients with completely incompetent cardia and Barrett's. I didn't try before, so I can't tell you my experience because I'm a cautious person who tends to be safe. So till now, I feel safe if he is mild, moderate esophagitis or reflux to have one anastomosis. But if he has severe gastritis, incompetent cardia, I will just go for the Roux-en-Y because I know that Roux-en-Y is the solution, the permanent solution for this Barrett's problem. If we put a scientific paper about patients with Barrett's to do one anastomosis gastric bypass and see the results and let the patient sign a consent that he has Barrett's and he will be followed up for like years, I will be happy to do that, and then I will involve in scientific paper like that, and then I will do it. But till this time, I can't go for one anastomosis gastric bypass in patients with Barrett's.
Professor, regarding hiatal hernia, so which size of hiatal hernia you prefer to repair, or you never
Yeah.
repair?
No, I repair sizable hernias like 3 or 4 centimeters. Less than 3 centimeters, I usually don't repair it because after doing my anastomosis and after doing my pouch, I usually find all the pouch inside the abdomen, nothing in the chest. And even with small hiatus hernias that go and up and down, I don't fix it because it has no significance and the patient doesn't complain at all after the operation. For big hernia that can take the esophagus out completely, but usually this is not the case in most of our Egyptian patients. Most of them don't need obesity surgery. So I don't need lots with big hiatus hernias with morbid obesity. I don't this kind of patients a lot. Moderate 3 to 5 centimeters and I fix it. I usually see small hernias and I don't fix it, but the big ones I usually don't see it. It's rare.
Regarding pre-op endoscopy, what is your protocol, and also H. pylori eradication?
Yes, if the patient complains of any kind of hyperacidity and 1 second. If patient complains of any kind of of hyperacidity or symptom of gastritis, and he did upper GI, we usually with the upper GI do biopsy for the pylori and we eradicate it. But this is in case of the patient complained. If the patient didn't complain, we usually do the operation without any further investigation. After the operation, by a year or two, if the patient comes and complains of gastritis, I will do upper GI and check the H. pylori and eradicate it. But it's not my protocol to do eradication of H. pylori for all my patients.
And also endoscopy.
Yes, endoscopy. I don't do endoscopy for all my patients. I usually do endoscopy for my complaining patients. If the patient is fit, he didn't complain of anything before, I usually don't put. It's not in my protocol to do endoscopy for all my patients.
Excellent. And already you have mentioned also in post-op, there is no protocol for follow-up with endoscopy. Only in symptomatic patients, you prefer endoscopy.
Yes.
And what was your finding in that in those symptomatic patient? Have you faced silent? Definitely, they are symptomatic patient. Patient is with so abdominal pain with any maybe symptom of GERD. So also, have you faced this marginal ulcer in such a cases?
After one anastomosis gastric bypass,
Yeah, symptomatic patient.
symptomatic patient with marginal ulcer.
Yeah.
Yes, yes, it's not a lot and it's not usual, but we face it like yearly. We see some patients with symptoms of gastritis, and it's easy to take them to the endoscopy and to make sure that they don't have marginal ulcers. And as I told before, we usually find early cases of marginal ulcers because I follow my patients by myself. If the patient has any attack, even of mild hematemesis, I will go for endoscopy. If the patient complains that he can't eat or tolerate meat for a long time, I will go for endoscopy because after one anastomosis gastric bypass, you have to check if the patient is not eating well meat, that he has no one of two things: bile in his esophagus, because this will not give him ability to eat meat, or marginal ulceration. So it's my indication that the patient says that I can't tolerate water or meat, and then I will go for endoscopy to check that everything is okay. And it's easy to make it. So usually we detect these kind of patients early because our patients is under our eyes.
Abuzed, what is your overall? So it's excellent. What is your protocol for PPI in these cases after MGB? Have you any protocol?
All my patients take PPI for 6 months. I give PPI in the first month twice per day, 40 milligram twice per day, and then I shift to one tablet 40 milligram in the morning 5 months. So it's for total 6 months. And I know that some surgeons just for 2 months, some surgeons just for 3 months. But for me, I think that 6 months is good for the patients. And there's theory that we don't need a lot of proton pumps after the one anastomosis because you have bile inside and it's buffering the acid. But I see that the omeprazole has good effect on the ability to eat proteins after the operation. So, in my opinion, I'll still use the proton pumps for 6 months.
Excellent. So regarding this, because you have mentioned also, yes, now PPI, this is your standard, and also you maximum you use for 6 months.
Yes.
So my yes, yes, and also we have buffering effect of definite bile in these cases, and due to this there is less chance. My question, sir, regarding intractable marginal ulcer. So now you have experience of 10 years, more than 1 decade of. And during this period, have you faced any intractable marginal ulcer after MGB?
Yes, I faced them, but most of the cases I saw was not our cases. It was from other surgeons, and it was in patients who were smokers, or who had short pouch, or had a big anastomosis. I don't know why, but I saw this kind of marginal ulcers in patients who had a anastomosis of 6 centimeters, maybe because the circumference of the anastomosis was big and has more area to be in contact with acid and bile, and it was up and the pouch was short. So in these patients, if it's intractable marginal ulcer or impending perforating, because we saw one case of impending perforation of marginal ulcer, and in those cases, we removed this part of marginal ulceration and we did small pouch up there and we did Roux-en-Y gastric bypass and the patient was okay. But I have to say that after we changed our technique, long narrow pouch, 3 centimeters anastomosis, we don't see lots of intractable marginal ulcers that need revision.
So excellent points, really, especially for our youngsters. So how we can prevent marginal ulcer if you follow standard technique, if
Hmm.
you follow all of these guidelines, then definitely there will be less chance of marginal ulcer. Because the
Yes,
main concern of bariatric surgery, especially anastomosis gastric bypass, is marginal ulcer, and you can prevent such a situation.
yes,
Sir, excellent. So regarding so another question, because you know better than me, sometime patient stops to lose weight. So yes, you did all standard that steps. So now 200 centimeter, everything, BP limb, everything was standard. But patients stop to lose weight. So patients lose just 40%, 30% excess body weight, but now stop. Have you faced and what you will do in
yes.
such a situation?
We can see this situation in patients with previous banding and previous sleeve. In some cases, you can see this because losing weight after previous procedure is less and slow than the standard procedure. So, in some patients, we have less weight loss, excess weight loss. But actually, these kind of patients, especially after the band, are accustomed sweet eaters. So after the one, I suppose, a gastric bypass, doing 2 meters bypass and everything, they will still eat bad and they will still have malnutrition. So thinking that doing more malabsorption will benefit this kind of patients it's not the case. So if somebody will tell me because that you did 2 meters, if you had like 3 meters or 4 meters, you may had some good weight loss, I will tell them, excuse me, I don't agree at all. Because you are doing a diseased patient instead of healthy outcome. In my opinion, this kind of patients need to be treated and to be learned. We have to learn them to eat well and to eat meat because now you don't have restriction. You can eat well, you can eat proteins, you can eat vegetables, you can eat fruits, and by this you will lose weight. And if you keep on the sweets, you will have dumping one time, and then your body will be accustomed to the dumping, and then you will eat sweets as you want. And at the end of the day, you won't lose uh, more weight with any kind of procedures. It is nonsense to make malabsorption more malabsorption for this kind of patients because these patients will have at a time edema, hypoproteinemia, because they are not eating proteins at all. So, usually with this kind of patients, I will tell them you have to eat proteins. And I keep telling them eat proteins till they lose weight. If these patients eat protein, they lose weight. And the problem with these kind of patients, I repeat again, is that they eat bad food.
Yeah. What is your opinion about medication, especially nowadays in market we have lot of injections and so GLP-1 like this. So
Yes.
have you any
Yes,
experience?
yes, yes. I can say that Saxenda is doing great job in Egypt regarding the 10 kilograms extra. But this is not our field because we're dealing with morbid obese, and most of the morbid obese will just lose like 10 or 15 kilograms with this kind of medications, and they will stop. So it's not our competitor. But if the patient had operation and needs a push, we can use this kind of GLP-1 treatments. But I prefer it usually with the sleeve because in the bypass, we already have all our tools with us. We just need the patient to follow the instructions of eating.
Professor, have you any presentation or video to show us?
Yes, I'm just trying to share the video through the screen share screen, but it doesn't. Okay,
Work?
I will just share the entire screen. Okay, 1 second. I will try. Okay, just let me share the entire screen. Okay, and I will show you video if you can let me share the entire screen.
Yeah.
Okay.
Now we can see your video.
No, no, no. I will share you some videos, but please let me share the entire screen. Okay. Just give me permission to share entire screen.
Sir, you can share because
No, no,
now,
no, no. Choose. I need you to give me permission to share the entire screen, not this video alone. I need to share the entire screen. So I think I need permission to share the entire screen.
no, no, you can stop the sharing, then you
Okay.
will
All right.
back.
Okay. All right. I will try
Yeah,
right
yeah.
now.
Please stop sharing.
Mhm. You see the video right now? The entire screen?
Yeah, we can see.
No, no,
Now,
no.
now you're sharing.
Can you see the video right now?
Yeah, we can see your video.
No, not the one. Uh, Not the one here.
Yes.
I'm trying. I'm trying to share the entire screen. Can you see the entire screen right now?
Yeah, yeah, you have shared, and again you start to show us this
Yes,
video.
yes. I'm just moving fast. Okay. All right. I'm just trying to make sure. Okay. Can you see here that the we are dissecting the sleeve? We are setting the lesser curve in this kind of. This patient had like 4 operations before. You see, right, Dr. Imran, please.
Yeah, yeah,
Do you see
yeah.
that
I can.
I'm dissecting right now the lesser curve, right?
Yeah,
Okay. So right now, this patient had like band, open band, then removal of open band by open method, and then she had balloon. After removing the band, she had balloon twice, and then she had sleeve. So she had like 5 procedures before she came to us. Here you can see that I'm dissecting the sleeve. I'm dissecting the lesser curve. I'm opening in the lesser curve. I'm introducing my stapler from below
yeah.
up, and it's above the incisure, above the antrum. Just you can see here that I have a very long antrum, very long
Long
pouch.
pause. Yeah,
Yes,
yeah.
and here is the site of the previous band because the band was in the mid of the stomach. I'm opening here an enterotomy and gastrotomy, and I'm doing here the 3 centimeters anastomosis. I use multiplier usually to make my anastomosis. If you can see that this is the linear anastomosis, and then I close my defect with
Professor,
continuous.
this was now also 200 centimeter from Tits
Yes,
ligament.
this patient was 200 centimeters from Treats ligament, and as you can see at the end, I placate this pouch. This pouch was not that big, okay, but still, I'll placate any pouch I have because any kind of restriction with with the one isomosic gastric bypass will benefit this patient. So I placated the pouch in this patient. I will show you another video here. Okay, I will show you here another video of VBG to one anastomosis gastric bypass. Okay, you know that VBG is popular in Egypt, and we have lots of cases of VBG in Egypt. As you can see here, we have lots of adhesions with the abdominal wall because it's an open technique. And then, as you can see, this is very old video, like 6 years ago, because this is one of the early cases of VBG. But I like to present this video because this is our early work. And still, I know this patient, and this patient is my friend now, and she is like 7 years right now, or 8 years, maybe 8 years after changing from VBG to one anastomosis gastric bypass. She worked in filmmaking, and I think she is doing great after the operation. So that's why I'm presenting this old video of her, because this proved that this operation can last for years. As you can see here, that we have the site of the previous VBG. We are dissecting the pouch from the liver, and right now we are trying to reach the mesh site, and you can see that the adhesion with the mesh with the liver makes dense adhesions with the liver, and we are trying to dissect all these adhesions. Usually the dissection can take like half an hour or sometimes an hour in patients with dense adhesions. Here you can see that we found the mesh, and we are trying to dissect the mesh and cut the mesh from the stomach. The technique after the VBG, after previous VBG, my technique is different from some surgeons because I go below the mesh. You can see the mesh right now, Dr. Imran, right?
Yeah, we can see.
Yes, yes, and you can see the proline stitches that we put.
Yeah, we can see.
Yes, and what I do right now is usually that I make an opening on the greater curve to make sure that I'm going on my right place. I'm removing all the proline stitches, and to make sure that I will go up there. I will go away from the old pouch, because the normal pouch of the VBG is usually like less than the bougie, because it was made on a rail. So usually it's less than the or equals to the 36 French bougie. I remove the mesh. I introduce 36 French bougie to make sure that the pouch is now connected with the rest of the stomach, and then I go as usual below the mesh, above the antrum, to make my pouch. As you can see here, okay, I'm doing my pouch below. As you can see here, it's like 3 centimeters below the mesh.
Below
Below
definite
the
crop.
mesh. Below the mesh. So
Yeah,
right now we have the mesh, we have our anastomose below the mesh, and this firing is the most important firing, because in this firing I'm making sure that I am having access to both pouches, the old pouch that I had and the new pouch that I will create outside the old pouch. And this is very tricky and risky, and most of the surgeons won't agree with me and will say that I will have ischemia on this lateral pouch because it's separated from the main pouch. But this is not the case with the VBG, because in VBG you only staple, you don't devascularize the pouch, and you don't separate the pouch from the rest of the pouch. So right now what we are doing is we are making a safe play after the VBG. We are going outside the old pouch, leaving like new small rim of stomach outside the pouch, connecting. I call it the pantalon pouch because it has two legs, one the old pouch and one the new pouch, and the base of the trouser is the common pouch that we have below the mesh. This technique I did for like till now for like 35 cases, and I didn't have any kind of ischemia, thank God, in the new pouch. And all these patients lost weight like any other VBG. They lost weight even better than after band. So, in my opinion, this is a solution to do a VBG after to do one gastric bypass after VBG, because what I see that most of the surgeons do the one gastric bypass like the Roux Y above the mesh, small pouch, and then one do anastomosis, and these kind of patients suffer from bile in their esophagus for the rest of their life, because the normal VBG in Egypt used to be done by stapler 10 centimeters only. So if you go above the mesh, you will have a pouch less than 10 centimeters, and you'll definitely have bile. In these patients, we have long pouch. It's a bit wider than the normal pouch because we have two pouches, old and new. But I can say that we have very, very good results in these kind of patients. Now we go to the ligament of Triads. We count 2 meters, and you can see here how I count the intestine. I usually count it 5 by 5, and then we proceed to the normal anastomosis. We do the enterotomy and put the 3 centimeters. I love this multi-file 3 centimeter Medtronic stapler. It's very nice stapler, very nice, very easy to use. Single use stapler, comes with its reload, and then I close the defect with Vicryl 30, and then make the test. Here we do the test, make sure that everything is okay. Then I do at the end hypnotic stitch. I don't call it anti-reflux stitch because it doesn't prevent the reflux, but I call it anti-reflux stitch. And then I put surgical snow. I love the surgical snow, and I use it as a hemostasis after the operation. These are my 2 videos for today. And if you need to ask me anything more, I'm willing to.
Yeah, Professor. Sure. So you can stop share.
Yes, I stopped sharing.
Now,
Right.
yeah, excellent. So excellent, really, and very useful. Definite, there is no doubt. So my question, so in sir, your experience, have you any bitter experience uh, during this 1 decade? So that always irritate you. Oh, this was something wrong for the patient after surgery, or I don't know. Have you take my
Complications.
question?
Complications, you mean?
Yeah, yeah, yeah.
Of course, in 10 years we have complications, and we have complications all the time. And our biggest fear right now is the bleeding. Okay, after sleeve, after one anastomosis gastric bypass, the biggest fear is usually the bleeding. You will say that bleeding is not that issue, but for me, I think that it's the main issue, because the other aspects of complications are usually manageable and long term, but short term complication is disastrous. So we take care usually about the bleeding. We make sure that if there is big vessel, I will clip it before I cut it with the ligature or the harmonic. I usually use the harmonic all the time. The staple line, I put the snow after I finished. I put some clips if I have a bleeding from the staple line. So our big concern, and I can say that we have like 1% of our patients bleeding after the operation, and we need to manage them. And this is the main complication. Marginal ulcers, as I said before, is rare. We can count it in thousands. We can say that it's like 3 in 1,000, and we don't count it in hundreds. And the intractable marginal ulcers are rare right now. And also with the other complications, uh, iron deficiency anemia is one of the greatest complications after the one as was a gastric bypass. Still, we have like 5% of our patients have iron deficiency anemia. It's less after we changed after I changed the technique, because if you don't have bile in the esophagus, you eat good food, you eat meat, and you have less anemia. I saw the anemia more in patients who had shorter pouch, wider pouch, because they had bile in the esophagus and they didn't eat lots of proteins. Right now, if you eat good food, you will have less anemia. Uh, Other complications like pulmonary embolism. Pulmonary embolism, we can say that the DVT is like maybe 1 in 200, maybe. Uh, or we talked about bile reflux. It's still present. It's like 2 or 3%, and it's manageable. Uh, Internal hernia, I didn't see internal hernia. I know that there is some literature saying that internal hernia is possible after the one anastomosis gastric bypass, but I saw the video and I saw it. It was like a twist in the anastomosis. It was not like actual internal hernia. So I can't say for definite that we had a problem with internal hernias. That's it.
Sir, excellent. So, if we summarize, so the because really it was very positive and very informative, because this is our main target. Now, someone is talking about MGB who is sharing his personal experience, and in my opinion, this is great opportunity, especially for our youngsters. So, if we summarize, if you have any message, just if I ask for youngsters
Yes,
who is
yes,
now
yes.
going to start MGB, which steps are very important so for doing MGB for better results?
Okay. I will just put 2 minutes message. First, pick your patient. Okay. I'm different from other one anastomosis gastric bypass. Some of the one anastomosis gastric bypass surgeons that I do all spectrum of procedures. I do Roux-en-Y, I do sleeve, and I do one anastomosis gastric bypass. Of course, one anastomosis gastric bypass is my favorite, but still I have both tools in my hands, sleeve and one Roux-en-Y gastric bypass. So please pick your patient. If your patient is a smoker, male smoker, pick the sleeve. Go for the easy one. Pick the sleeve, and you will have good results for this kind of patients. Don't put your smoker patient in the risk of marginal ulcer after the operation. Pick your patient. If the patient is low BMI, young patient, and fit, and everything, and he just needs to lose like his BMI is 37 or 38, I will just go for sleeve also. So I'm not doing one osmosis for all my patients. One osmosis is a strong operation. It's very good for morbid obese. It's very good for diabetic patients, but in some patients, sleeve may be better. Okay, so I'm not afraid to say that sleeve. Patients coming to me, and I will say to him, just pick the sleeve or pick the Roux-en-Y. Okay, If you pick the one anesthetic gastric bypass for your patient, then do it right. In my opinion, and it's my opinion, is not the right thing, but it's my opinion. In my opinion, long narrow pouch, start above the antrum, make long pouch like a sleeve, over 36 French bougie, little bit laxed over the 36 French bougie. Make 3 centimeters anastomosis linear or transverse as you wish, but for me, linear is easier. Close your defect with 3O Vicryl or VLOC, and make sure that you put the anti reflux, but it's not anti-reflux, it's hypnotic stitch to relax the anastomosis. If you have long narrow pouch, you will definitely have lax pouch that can anastomose easily with any kind of intestine, even if you have heavy momentum. Please, when you start your practice, make the patient on diet 3 weeks before the operation. This will make your life easier because the momentum will be easier and lighter to make your anastomosis, and it will be very easy for you to make the anastomosis. Some tricks don't work from the mid or between the legs, work on the right side of the patient. Tilt the patient on your side and raise the head as high as you can, especially during doing the pouch. When doing the anastomosis, you can lower the head a little bit. I mean that it can be still anti-trembling, but not as high as the doing the pouch. It's it's easy to do the one anastomosis gastric bypass if you have skills of stitching, and I think that one anastomosis gastric bypass will be one of the leading operations all over the world in few years.
Sir, excellent, excellent. Really, a great message, I think, for our youngsters. So, what is your diet protocol after MGB?
My diet protocol after MGB is the same like after the sleeve. I have 5 days clear fluids, 5 day thick fluids and yogurt, then 10 days blended food, and then 10 days mashed food. And after 1 month, I return to normal food. So basically, I return to normal food after 20 days, but in the last 10 days of the first month, I mash it to make sure that the patient is ready to eat. And then we eat normal food after the first month. We have 5 meals: breakfast, normal breakfast, but we stay away from the fatty cheese and white bakeries. And then we have snack, fruits, or tuna sandwich, and we love the tuna sandwiches. And then we have lunch and early dinner, and both meals should contain lots of proteins like big portion of meat or chicken or fish, with vegetables, with salad, Mediterranean style diet, as Dr. Rutledge say. And then at night before sleep, you can have 1 cup of yogurt before you sleep. This is the usual diet. I tell my patients stay away completely from fizzy drinks, no fizzy drinks, no smoking, bit of alcohol, don't drink alcohol a lot. And of course, no sweets, no sugars, because it will cause you dumping and it will slow your weight loss. We don't like the white bakeries because it gives flatulence for our patients, and we don't like crackers. This is our the
That,
summary of my diet. All right,
sir, excellent. Really, Professor Abouzeid,
thank you,
so much thanks.
thank you very much.
Really, your time. I know you are so much busy, and at this time of night, this was great honor, sir.
It's my
And
honor, and I'm very pleased to be with you today. Thank you very much, and I wish that we meet together in reality soon, inshallah.
sure,
And
sure,
thank you very much
inshallah,
again.
inshallah,
And it was
inshallah.
my pleasure and honor to be with you. Thank you very much.
So thanks, brother, and also because we will also continue our this series. So next we will have series of sleep gastrectomy, then Roux-en-Y gastric bypass, then so this metabolic surgeries in low BMI cases, and at the end we will have redo. And we have scheduled till June 2023, definite in so coming series. Also, we need your support and your
Yes,
guidance.
sure.
We also, because this your session, and this session is second last. So our last this session will be with Professor Carbao just this Thursday, day after tomorrow. So we will be live again, because Professor is easy to be live at Thursday. So we will be live same time, 10 p.m. Dubai time, and also 8 p.m. That will be so CET, though European time, Central European time. We will be live with Professor Carbajo, and then at 13th June, so we will have a sum up session. So most of legends will be there, and we will try our best to sum all of these discussions. And we will have so moderators like Professor Ariel Ortiz, Professor Asim Shabir from Singapore, and also Dr. Tansir from Islamabad. Same time, so Professor Amir Khan from UK, he will chair the session, and also many of these panelists like Helmut Billy, so Professor Carbajo, Professor Robert Rutledge, Laurent Layani, and also so many of these. So maybe I miss. So they will be in expert panel. And so my viewers, really, so thanks. You are followers. We need your support. If you have any question, please ask any question from Professor Carbajo, because day after tomorrow he will be live with us. And Professor Abouzeid, really, so thanks. So thanks for your
Thank you very
participation.
much. Thank you. Thank you very
And
much.
great honor for me, sir.
Thank you very much. Thank you.
Thanks a lot, sir. Have a
Bye-bye.
nice time. Thank you. Bye. Thank you, sir.